Good morning, Dr. Brailer.
Good morning, Dr. Agarwal. Really nice for me to see you.
We are seeing each other after a very long time.
Yeah, that I agree. I hope you all are very well.
Yeah, we are all keeping very well, and hope you and your family are also keeping well.
Yeah, that's here the case. We saw
morning.
all the. Good morning.
Good morning, Dr. Baila is Dr. Gaur.
Yeah, good morning, Dr. Gaur. And you're also well because we saw all these slides, all the pictures from the pandemia in India. But you and your families are well.
Good morning, Dr. Bella.
Good morning.
I am Dr. Prasad. I think previously we met in Patel Chest, I hope.
Yeah, I agree. I can remember it was a good time.
That time I was director there. Now I'm in Lucknow at present.
Okay.
It is near Delhi.
Yeah.
If you remember, Dr. Baila, we met at least 4 times in Patel Chess Institute when I was director. Then,
Yeah.
and
good morning, Dr. Singh.
Then in the NAPCON, then in the allergy workshop, and then we met in the in Noida also at a medical college. Dr. V.K. Arora invited me, so I met 3-4 times with you.
Yeah, and I think one time I attended your asthma chat, and this was really very interesting. Yeah.
And then there was a Dr. Talwar has done a conference. Again, I think you were there.
Good morning, sir. This is Dr. Pradum Sharma from Jaipur.
Good morning.
Morning.
Morning, sir.
Morning, sir. I'm from Pune, sir.
Yeah,
I had been for the master class in 2019 to you.
Yeah.
We learned a lot from you, sir.
Yes, long time has gone. Much time has really gone. It's long ago. And I'm really happy to see you all. What's the situation in India at this time? The pandemia is going down, or?
Dr. Brailer, we started these seminars, Dr. Nagen Prasad initiated about 13, 14 months ago.
Yeah.
And we are holding it regularly. And we try to get experts in respective fields to participate. And we try to keep in touch with each other. That is number one.
Yeah.
We try to keep updated with the field. With this, keeping these regularity is a very difficult task, but Nagen Prasad and Dr. A.B. Singh are doing nice job. They are keeping the things going.
Yeah, that's great.
Now we are thinking that we should record these lectures and put it on this website of Indian College of Allergy and Applied Immunology, so that if somebody has missed to attend this lecture, they can hear that lecture later on.
I think that's okay, yes.
Welcome, Dr. Brailer.
Welcome. Good morning.
How are you, sir? Good morning.
Very well, thank you. Yeah, here it's really very early in the morning. We have 7:30.
Oh, so early.
Yeah.
Maybe you could have postponed it to the second lecture after 1 hour, then it would have been better.
Okay.
Maybe next time, yeah.
No, it's okay. Very early in the morning is okay.
Yes. A lot of floods in Germany, I heard.
Yeah, I agree, but not in Münster at this time, but in some cities around here, we had really very severe floods and more than 100 of cases of death. And many houses were destroyed, and some cities, small cities, were really destroyed completely. Really terrible. It's like a monsoon. We never had it before. Yeah.
Yes, very bad.
Yeah.
Has Nagendra joined?
Where is Nagen Prasad?
You should come. There is no flood in Bangalore.
Yeah.
Bombay is bad.
Oh. And it's very hot in India at this time.
We are almost
Humid.
almost the time to start the program, but it is up to you, Dr. AB Singh, whether you want to wait for
Waiting for
I will just see. I will just try to contact Nagendra. Once he says okay, we'll go ahead. Then I will.
Okay. He joined a few minutes ago, but then his video was not working. So
Good morning, sir.
Okay,
morning.
welcome. We are
Thank
looking
you.
for you only.
I had some technical problem. My video is not working.
Your camera
So
is blocked.
welcome. Good
Your
morning
camera is
to
blocked.
Dr. Adolf. Well, and welcome to this Allergy Asthma chat program. I'm very happy you have agreed for this session. So we are starting this program now. And today we have two important speakers. One, Dr. Rudolf Breller. He is from Manchester, from Germany. He will be speaking about allergen-specific IgG antibodies in treatment option for allergies. We have another speaker from Delhi, a senior chest physician, Dr. G.C. Kilani, and he'll be speaking about management of asthma in 2021. So if the speakers agreeable, then I'll put it onto the recording mode. For this today's program, I'll be inviting Dr. S.N. Gaur to chair the session and proceed. Dr. S.N. Gaur. Dr. S.N. Gaur is a president of Indian College of Allergy and Applied Immunology, and he is a ex-director of Patel Chest Institute, and he is a consultant now in the Delhi. And I invite Dr. S.N. Gaur to proceed with the present meeting. Dr. S.N. Gaur.
Thank you, Dr. Nagendra. Now we can start this session. It's a very important session because we have got two very important speakers. And I think most of us know Dr. Adolf Breller because he is coming very frequently to many conferences in India. I actually met him 4 or 5 times and I know that what clear concepts he has got about allergy, is working his own allergy. So Dr. Rodolph Berer is from Germany and he is at present the professor of dermatology, senior physicians, and head of the department of allergology at Münster. And he has been at the various places. He has education in Göttingen, then he's got at various places in Gelfield, and then again Göttingen, music of this thing, Münster Department of Dermatology. So since 1992, he has been senior physician and head of the Department of Allergy and Department of Dermatology at Münster. He has lectures on various places, and he's got more than 1,000 lectures on national and international conferences. Professionally, here Germany Contact Allergy Group, he's a member of that. Society of Occupational Environmental Dermatology, Society of Dermatopathology, Society of German Allergologists, and German Society of Allergy and Clinical Immunology. His major interest is immediate type 1 reactions and immediate allergies, allergic rhinitis, asthma, and insect venom allergy, cellular activations due to carbohydrate and protein epitopes of glycoproteins, mechanism of allergic reactions, and modulation of the immunological response due to allergen-specific immunotherapy. Now, this is the brief introduction of Dr. Rare, and I can now request Dr. Brenner to please start his talk of today.
Okay. Thank you very much for the introduction, Dr. Gauer. It's a great pleasure for me and a great honor for me to have the opportunity to speak here today about some new strategies of inducing tolerance in patients, in allergic patients against special allergens. I hope you can see my slides. Is that correct?
Yes, perfectly.
Okay. Okay. And I'm really happy to see you all because I heard a lot about the corona pandemia in India. I know that you are hardly affected here in Germany. At this time, we have low numbers of patients, but again, here, although the number of patients is increasing at this time, and I think at this time we are in the time of the pandemia, and therefore I'm really happy that we have the technical options to do such presentations. Therefore, today I will speak about allergen-specific IgG antibodies. And the question is, will these antibodies will really become a treatment option for patients suffering from allergies? And I will focus on asthma and also a bit on allergic rhinitis. And looking here to asthma, I think you all know these all are elictors of asthma attacks in asthmatic patients. And these are especially the allergens. And in Europe, but also in India, allergic asthma is really very important. We all know that. And I think more than 60% of our patients suffering from asthma are really sensitized to air allergens. And the most important air allergen here and also in India is the house dust mite. We have on the other side pollutants, we have cigarette smoke, we have bacteria, we have detergents, and we have also viruses. And we know a lot about the inflammation. And we know it's normally an eosinophilic inflammation in all those patients who suffer from a T8, from a T2 high asthma. And therefore, treatments against eosinophils are an option in the treatment of severe asthma. On the other side, you will see here also the IgE antibodies are of importance. And you know, omalizumab, the anti-IgE antibody, is an option to treat allergic asthma. And we have the anti-IL-5 antibodies. They are directed against eosinophils. And on the other hand, we have the dupilumab, and this is an antibody against IL-4 receptor. And this agent will block also the IL-13 action. Therefore, these are options in asthma, but the question is, what are really anti-allergic treatments? And at this time, the biologics are really not really anti-allergic. Looking perhaps here to the GINA guideline, then you will know these are the new recommendations. And looking to these recommendations also for the patients with the severe asthma, therefore with those ones who will be treated by step 5, here we have the recommendation to refer the phenotypic assessment and to look if we can use anti-IgE, anti-IL-5 or anti-IL-5 receptor antibodies or anti-IL-4 receptor antibodies. And secondly, we will treat patients with oral corticosteroids. Therefore, to all the recommendations worldwide, the biologics are of increasing importance in the treatment of severe allergic asthma. Again here, asthma inflammation. And for the asthma inflammation, the allergens are really very important. And we know we need a barrier destruction, and allergens must destruct the barrier. This may be the skin, this may be the mucosa, and the allergens will meet the dendritic cells, and allergens will be presented to T cells and to B cells, and nevertheless, we will get the expansion of specific IgE antibodies. Here we have also the Th2 cells, and you will see here mediators, and again, IL-5 and IL-13 and IL-4. and IgE are really important for the asthma inflammation here in the lung, but nevertheless, that's the same also in the nose, and it's comparable with the skin. Therefore, we have an allergic eosinophilic airway inflammation in many of our patients. On the other hand, we can have a non-allergic eosinophilic airway inflammation. Therefore, here we have the eosinophils, but this is not driven by IgE and not driven by antigens. This is what is thought at this time. Therefore, we frequently speak from the type 2 inflammation. And what is really type 2 inflammation? And this is from the GINA guideline. Type 2 inflammation is found in the majority of people with a severe asthma. Therefore, that's really important. The most asthmatic patients are type 2. And type 2 inflammation is characterized by cytokines. And these cytokines are IL-4, IL-5, and also IL-13. Which are often produced by the adaptive immune system on the recognition of allergens. And again, here the allergens are important. And if we really have a non-allergic hypereosinophilic asthma, the question is, do we really recognize all the different allergens, or are there some pan-allergens which we cannot recognize at this time? The immune system may be also activated by viruses, by bacteria, by irritants, via the production of IL-33, IL-25, and TSLP. And also anti-TSLP will become as a treatment option for our patients very soon. Type 2 inflammation is often characterized by eosinophilia or increased FeNO and may be accompanied by atopy. Therefore, many of our asthmatic patients will have comorbidities, and these comorbidities are allergic rhinitis, are food allergy, and this is also the atopic dermatitis. Therefore, all these diseases which are called atopy. Type 2 inflammation rapidly improves when ICS are taken regularly and correctly. This is clarified as mild or moderate asthma. In severe asthma, type 2 inflammation may be relatively refractory to high doses of ICS, and it may respond to oral corticosteroids, but the serious adverse effects mean that alternative treatments should be thought. Therefore, in GINA 5 patients, we have to check if we can treat with those biologics we have at this time. And if this is possible, normally this is seen as a clear indication for such a treatment, but you all know these treatments are really very expensive at this time. Therefore, allergic asthma is most easily recognized asthma phenotype, which often comes in childhood and is associated with a past or a family history of allergic diseases. That is really very important, as eczema, allergic rhinitis of food or drug allergy. And then we have the option in allergic asthma to treat with anti-IgE, the omalizumab. We have the eosinophilic asthma, and here we can treat with anti-IL-5 or with an anti-IL-5 receptor antibody. At this time, they are regularly can be used for the treatment of asthma. And the newest one is for the eosinophilic asthma or the asthma with an elevated FeNO. And then we have the anti-IL-4 receptor antibody. This is a dupilumab, and this will also block the action of IL-13. Therefore, it's recommended to search for allergies in all our asthmatic patients, to not oversee the allergic component in our patients. You know that the eosinophils are very important, and also eosinophils should be analyzed in all our asthmatic patients, and frequently we will find the high eosinophils. But on the other hand, you know that also high dose ICS will reduce the eosinophils, and you will not find eosinophils when you will treat patients with OCS, with the oral corticosteroids. We have additional indications for the biologics, and these biologics are registered in Europe and also in the US. And here, for example, omalizumab is registered for the chronic idiopathic urticaria, and also at this time for the nasal polyps. The mepolizumab is registered also for hypereosinophilic syndrome and also for the eosinophilic granulomatosis with polyangiitis. At this time, not in Germany, but I think we will have the registration soon. Benralizumab is not indicated officially for all these other diseases, but here we have the dupilumab, and this is also registered for the chronic rhinosinusitis with the nasal polyps and also registered for the treatment of atopic dermatitis. Therefore, it's really very important to look also for the comorbidities of our patients, and some patients may be treated for asthma and for the comorbidities with one of these biologic agents. It's important to check the regulatory approvals and the EGLPD criteria in the different countries. But I think also in India, you will have the registration of omalizumab. I know that. And I think you will also have the IL-5 antibodies. And I think you will nowadays also have the dupilumab, the IL-4 receptor antibody. But the question is it really an anti-allergic treatment? And here at this time, we have the omalizumab. And omalizumab will bind to the free IgE in the serum. That is important. And you know very well, this is an IgE molecule. And normally the allergen binding site is here in this region. And the binding site to the receptor on the cell surface is here, the C-epsilon-3 region of the IgE. And what does omalizumab do is that we here have an antibody directed to the binding site of IgE. Therefore, we can affect only the free IgE in the serum, and we cannot affect the IgE which is already bound on the cell surface. That's quite important, and if you will treat asthma patients, then you will know that we will check for the effectiveness of this therapy about 4 months later, and then we will see the effect. It was thought that anti-IgE is really an allergy treatment, but at this time, I think we know that it's not really. We have different IgE antibodies, and different IgE antibodies have been proved for the treatment of allergic diseases. And again, you will see here, this is IgE, and this is the antigen binding site, and we will have an antibody directed against the binding site directly, then this antibody will produce anaphylaxis. All the antibodies we have are directed against the 3-epsilon-3 region. What antibodies against C-epsilon-2 or C-epsilon-4 region is really not known, because these antibodies have not been proven in any trials, and I think they are not available at this time. Nevertheless, therefore, it was thought that the anti-IgE antibody treat allergy by withdrawing IgE. This was the theory, and therefore, if we will treat patients long enough, it was thought they will not be allergic any longer. And it has been demonstrated that omalizumab is effective in the treatment of allergic asthma. It is effective in the treatment of allergic rhinitis and also in the treatment of food allergy. But it works also in urticaria. And you know very well, urticaria is normally not an originally IgE-mediated disease. Therefore, also other mechanisms must be responsible for the effect of omalizumab. And perhaps you know, there is another antibody, and this is the IgE antibody ligelizumab. And ligelizumab is an anti-IgE antibody with a higher affinity compared to omalizumab. And therefore, it was thought ligelizumab must have a stronger effect compared with the omalizumab. But the trials failed when patients suffering from allergic asthma were treated. It was really ineffective. On the other hand, ligelizumab is highly effective and more effective in the treatment of urticaria. And again, this means the anti-IgE treatment is not really an anti-allergic treatment. The mechanisms are not fully understood at this time. We know we have a reduction of virus infections. We know that we may have a silencing of effector cells, especially of the mast cell. We don't know exactly why. This may be a downregulation on receptors on the cell. And what I think is that we have effects of immune complexes. And looking very long back, about 20 years, then we have learned that mite allergic patients can be treated by specific immunotherapy. This is effective. But if we will treat patients with immune complexes, and these were complexes from IgG antibodies and the mite allergen, and if patients were treated with these complexes, it was more effective compared with the immunotherapy itself. And therefore, immune complexes may be very important for the immune system and very important for the regulation also of inflammatory processes. You know that TSLP may be an important molecule here, and TSLP, for example, is also important for the barrier, and especially of the barrier of the mucosa. And therefore, anti-TSLP, and I think the anti-TSLP will come at the end of the year for the treatment of severe asthma, may be useful in the allergic asthma, but also in the non-allergic asthma. And you see here, TSLP will be also important, also maybe important in some aspects of T2 low asthma. Therefore, this may be a more general treatment for patients with asthma. What is the anti-allergic treatment we have? And here we have the allergen immunotherapy. And allergen-specific immunotherapy, or AIT, we call it nowadays, may be a treatment option when allergy plays a prominent role. And this is also here from the GINA guideline, and therefore also a treatment for allergic asthma. And it will be effective, especially in those patients who additionally suffer from allergic rhinoconjunctivitis. Currently, we have two approaches. We have the subcutaneous immunotherapy, the SCIT, and on the other hand, we have the sublingual immunotherapy, the SLIT. And again, according to the GINA guidelines, in the past, we had a few studies in asthma which have compared immunotherapy with a pharmacological therapy or use standardized outcomes such as exacerbation. And the most studies have been done in patients suffering from mild asthma and not from the really severe asthma. The allergens most commonly included in allergen immunotherapy studies in those patients have been the host mite and have been the grass pollen. This is the statement of GINA. SCIT can be done if we will really find or if we can really identify the allergen. And the allergen must be relevant for the clinical course of the patient, must be really clinically relevant. Therefore, we have to look, is the patient only sensitized or is he really allergic? And sensitized means that the patient will have a positive skin prick test, that the patient will have specific IgE antibodies, but allergy means that these IgE antibodies are really clinically relevant. And there may be a difference. And for example, you may have also those patients with very high IgE, serum IgE, and these patients are suffering from atopic dermatitis. And you will find in the serum of these patients many or specific IgE against many different allergens. But if you will challenge these patients with the allergen, they will not have any symptoms. Therefore, this is a differentiation between sensitization and allergy. Therefore, the patient must really be allergic. In Europe, we use normally single allergen immunotherapy. And you know, in America, physicians prescribe multiple allergens for treatment. SCIT is really associated with the reduction in the symptom score and in the medication requirements. and improve allergen-specific and non-specific airway hyperresponsiveness. This is at this time demonstrated in trials. SLIT is also used in some trials. And again, looking to the GINA guideline, modest effects are identified in a systemic review of SLIT for asthma in adults and children, but there was concern about the design of many of these studies. The evidence for important outcomes such as exacerbations and life quality still remains limited. And especially we have a trial for SLIT with house dust mites in patients suffering from asthma and house dust mite allergic rhinitis. And this trial demonstrated a modest reduction of ICS with the high dose SLIT. Therefore, immunotherapy must be done with high doses of the allergen. Looking to the meta-analysis here, allergen-specific immunotherapy used for allergic rhinoconjunctivitis, and all these trials favor immunotherapy, and there is an effect over placebo. The effect was different in different trials. Do you see that here? And here you will see the SCIT trials, and also here we have a lot of trials. And again, here, these trials favor the effect of the SCIT over placebo. What with asthma, and also here we have the meta-analysis. And again, you will see here the trials for SCIT and here for SLIT, a limited number, but you will see again here there is an effect. This is the standardized mean difference, and therefore we have an effect of SCIT, and we have also modest effect of SLIT, and therefore this treatment is effective in the treatment of asthma. Therefore, in which patient we will use which treatment? And for me, it's important here, if you have patients with really severe asthma, then we have the biologics. On the other side, also to the GINA guideline, we can use allergen-specific immunotherapy, but this will be used more in these patients suffering from a mild asthma, because we know very well if a patient will have reduced lung function and we will have side effects of immunotherapy, this could be an asthma attack, and this could be life-threatening for patients with an reduced lung function. Therefore, I think that is important. Here we have the biologics, and here for the milder patients, we have the immunotherapy. Looking again, what is about the immune response on immunotherapy? And important for the patient, the clinical outcome, and the clinical outcome means the patient will have less rhinoconjunctivitis, will have less asthma symptoms, and need less medication used for the rhinitis and also used for the asthma. And we have some serological outcomes. And we have here an effect on allergen-specific IgE. This may be reduced over the time. And we have also an effect of allergen-specific IgG antibodies and IgG4 antibodies. And for a long time, we know that we will really induce these allergen-specific IgG. We have some cellular and cytokine outcomes, and there are effects on IL-5, on TGF-beta, on IL-10.
Can you please mute your mic?
Okay, no, it's better. Yeah. And we have effects on eosinophils, on basophils, on the effector cells, and also on the mast cells. We have an induction of regulatory T cells, of regulatory B cells, and so on. This is at this time important for the efficacy in clinical trials. But you all know we do not have a clear parameter which we can use to look for the efficacy of specific immunotherapy. Therefore, that's really unclear at this time. If we will treat patients by, in this case, subcutaneous immunotherapy, then we know we will bring the allergen into the subcutaneous. And again, here we have the allergen presenting cells, and the allergen presenting cell will take the allergen, will go to the lymph node, And in the lymph node, the immunological effects start. And you know very well that we have the induction of regulatory T cells and regulatory B cells, and we have also the effect on the plasma cell, and the plasma cell will produce these blocking IgG antibodies. But the question is, what is the most important effect of immunotherapy? Is it on the regulatory cells? And what are the effects of these blocking IgG antibodies? And you know, we have the effects on the T cell, on the B cell level, on the dendritic cell, and also on these effector cells. But what is really the importance of the specific IgG4? And allergy and immune tolerance is a condition of the immune system with a high degree of a plasticity due to an interplay of different mechanisms. And I think IgG antibodies, and I will focus on the IgG antibodies, are really important. But we have also the effect on the activity of effector cells. We have the expansion of regulatory T cells and regulatory B cells, and this is thought to be important for the long-term effects of immunotherapy, but it's really not completely clear at this time. Looking again to IgG antibodies. And years ago, and you will see this is a publication from 1996. And also at this time, the IgG antibodies were in the focus of the interest. And here, for example, there was an investigation on serum samples of beekeepers. And these beekeepers were allergic to bee venom. And in these beekeepers, specific immunotherapy has been started and has been done over 3 years. And we know in venom insect allergy, immunotherapy is really highly effective. And the most of our patients are protected from anaphylactic reactions after immunotherapy. And here they analyzed specific IgE, specific IgM, specific IgG, IgG1, and IgG4 antibodies to single bee venom allergens. And here it was used in immunoblot. And the efficacy of immunotherapy after the 3 years was proven by a challenge with a living bee. And it has been shown that patients who are protected from an anaphylactic reactions have more IgG4 compared with IgE to all, and that is important, to all the individual bee venom components against they were sensitized. And if the patient had more IgG4 compared to IgE, then they were protected. Therefore, it was thought that IgG is really very important in the effect of immunotherapy. And for a long time, it was thought that we really can analyze IgG and that the IgG level to the allergen is really correlated with the efficacy of the therapy. But this has been demonstrated in bigger trials. This is really not true. Here you will see such plots. And you will see here, for example, this is IgG, this is IgE. And here, this patient, for example, will have IgE against this allergen. This was before immunotherapy, and after immunotherapy, there's a very strong reaction with the IgG antibodies. And in some patients, we had nevertheless also after therapy a predomination of IgE antibodies, and we have no IgG antibodies. And therefore, it was thought that these patients have been not protected. Then a really big multi-center study followed, and this has been done on 362 patients. And in this multi-center study, these results could not be reproduced. And therefore, after that trial, it was thought that immunoblotting with IgE and IgG4 is not the predictor of the efficacy of immunotherapy. And then it was thought then the relevance of the IgG antibodies these antibodies are not really very important. And then it was started with the analysis of the regulatory cells. Nevertheless, we know if we will do immunotherapy, then we have the induction of IgG. And here, for example, this is a trial with house dust mite allergic patients. And here it was analyzed the concentration of IgG against Dermatophagoides pteroniecinus and also the IgG4 antibody, and also these both antibodies against the Dermatophagoides farinae. And here, these were patients treated with placebo and here treated with different allergen concentrations. And you will see here clearly that the highest allergen amount, which has been used in the patient subgroup and used the highest concentration in IgG antibodies against Dermatophagoides pteroniecinus and also against farinae. And you will see here also the strongest effect on the IgG4 antibody. Therefore, by several trials, it has been shown that specific immunotherapy will induce IgG antibodies. Again, here you will see the effect here on the IgG4. And in this trial, also house dust mite allergic patients have been investigated. And you will see here a stronger effect from SCIT compared to SLIT. Therefore, the induction of IgG4 is strong in SCIT, but modest in SLIT. What are the mechanisms and what are really the biomarkers? And you know, we will do allergen-specific immunotherapy and we will use high amounts of allergens. And therefore it's clear, yes, we will have here the induction of IgG antibodies. And what will these antibodies do? First, they can, it's thought, neutralize the allergen in the serum. And therefore, if IgG bind to the allergen, then the allergen may not be able to bind at this time to IgG. But nevertheless, that is a blocking function in the serum. And you know, in the serum, the IgE is not of that importance compared with the IgE, which is bound on the effector cells. And here you will see if you have on the effector cell IgE and IgG4, then it was thought here that we will not have a degranulation due to the allergen if there is a binding or a bridge building here between IgG and IgG4. Therefore, it may be that we have some kind of silencing of the effector cell. And this is thought nowadays to be one of the effects of the IgG4 antibodies. Nevertheless, the question is, why will one patient with IgG4 antibody will be protected from symptoms and another patient will not? And we know the efficacy of these IgG antibodies, which are built by different patients, and these antibodies are induced by immunotherapy, are really different. Some have a very high binding capacity and a high blocking capacity, and other individual allergens from other patients will have not these items. And therefore, the quality of the IgG antibody is really different in different patients, and that's important and that we have learned. Therefore, here again, you will find if we will have patients here, cat allergic patients, and if we look for FeLD1, and FeLD1 is the major allergen of the cat allergen, and in patients which are treated with the cat allergen, we will find the FeLD1 specific IgG. And you will see here, these are patients who had not immunotherapy, a control group, and these are the patients who had the immunotherapy. And therefore, yes, especially for the FeLD1, we have the induction of these blocking IgG, and these are induced by immunotherapy. And here it has been clearly demonstrated that these antibodies have really a variable blocking capacity and a variable affinity to the cat allergen. And that's important. Therefore, not all these antibodies are the same. If the induction of this blocking IgG is really a dominant protective mechanisms seems here to be unclear, but now we have data that these antibodies are of importance. Allergen-specific IgE can inhibit the binding between IgE and the allergen. The most specific IgE is in the serum, and therefore here we will have immune complexes, and they will be made from IgG and they will made from the allergen. Allergen-specific IgG suppress the development of IgE and anaphylaxis by acting through the inhibitory receptor Fc epsilon. And that seems to be the important mechanism. And again, you will see it in this slide. This has been published in the last year. Here, for example, you will see on the cell surface 2 IgE antibodies. This is an example with peanut. And we have the cross-linking over 2 IgE antibodies on the cell surface. Then we will have the activation of the cell, and here the degranulation of the mast cell. Here we have a cell and we have IgE and IgG. And again, you will see here, this will silencing the mast cell, and therefore we will have no degranulation. If this sensitized patient who has also IgG antibody to the peanut will be exposed with peanut. This is the steric blockade in the serum. Therefore, we have here the binding of IgE to the peanut allergen, and then this peanut allergen may not bind here to the IgE on the cell surface. This is a steric blockade. Therefore, we have different mechanisms how IgG may inhibit the allergic reaction and lead to tolerance of our patients. And for me, this was a very important publication from the last year. And again, you will see here the options of the inhibition of mast cells. And again, here you will have the allergen IgG complex. And again, here you have blocking IgG antibodies. Therefore, the antigen cannot bind on the IgE on the cell surface. And this was first, I think, why we called it blocking IgG or neutralizing IgG antibodies. But this may be important, and we have some of the old data where we treated patients with allergen plus IgG, therefore with the complex, and this has been effective, but these are studies about 20 years ago, and there have been no newer studies. Again, here you will see the mast cell inhibition, and you will see again here the theory. If you will have IgE and IgG on the cell surface, and you will have a binding here or a cross-linking between IgG and IgE, then this will inhibit the mast cell. And we know that we have an internalization of the receptors, and therefore we have a long-term silencing effect on effector cells. Nevertheless, the question is, looking for cat allergen or looking here, for example, for the peanut, we have some dominating allergens. But do we really need IgG against different components in an allergen or not? And if I will see this, that we have the internalization and that we really have here the long-term inhibition of mast cells, then it may be that one IgG antibody against one component of the allergen will silencing the mast cell also for other allergens, and that seems to be very important. And this has been demonstrated in animal experiments. And mice were sensitized in this case to peanut extract. And you know, in the peanut, we have some different allergens. We have the RH1. For example, we have the RH3, we have the RH2, and important are also RH4 and especially RH6. And therefore, normally, a peanut sensitized patient, and also in this case, a peanut sensitized mice, will produce IgE against different peanut components. And this means if I will have a sensitized animal and I can challenge with RH1 or RH3 and also with RH6, and the cell will set free all the mediators and will be activated. And then it has been demonstrated if I will take a mouse and this mouse is really sensitized to peanut extract and really have in the serum IgE against the different peanut proteins, and then I will treat the patient with, in this case, IgG antibodies only against RH2. Then the mice will become protected in the case of a challenge with the peanut extract. Therefore, we have really a long-term silencing and an inhibition of the mast cell activation, and also by an antibody against only one of the allergen components, an inhibition of the mast cell activation due to the whole extract. And this was really very new, and that's really very interesting, and that makes us interesting for the future. Therefore, mice were sensitized intraperitoneally, administering the peanut extract and challenging a mice or a mouse. Anaphylaxis may be demonstrated by a temperature fall. And a single monoclonal antibody against the peanut allergen RH2 protects mice in these experiments against the challenge with the peanut allergen. And therefore, here you will see it again. Therefore, here the mice sensitized to peanut, to the whole extract, was treated with RH2. And you will see here, these are the mice who have been really treated. They are protected compared with those mice who have not been treated with these IgG antibody. And you will see here also that we have a suppression of skin tests. Therefore, we can also suppress the skin prick test against here peanut extract by the antibody directed to RH2. And there are some other experiments, and you will see here we can take naive basophils from non-allergic donors. And if we will treat these cells with a serum of peanut allergic patients, and then we will challenge with peanut, then it's clear these basophils become sensitized to the binding of IgE antibodies. And in the case of a challenge, the cells here will release the mediators. If we will use these cells and we will give on the cells, in this case, a post-immunotherapy serum. And in this serum, we will find also the blocking IgG and then challenge the cells. Then we have a mainly reduced mediator release of these cells. And therefore, this clearly demonstrates that we have blocking IgE in the post-immunotherapy serum. And here we can give mixed pre and post serum to the cells, and you will see the same. If you will challenge the cells after that, they are protected. But if we remove IgG, then we will have the release. Therefore, the IgG antibodies are here important for the protection against the release of mast cell or of basophil mediators. Therefore, this may be an effect in food allergy, And therefore, again, here the IgG will be responsible for a protection of the patient, and the IgG may give patient really a tolerance against individual allergens. And this has been proven now in clinical trials on humans. And first, it was started with cat allergic patients, and you will see here FeLD1 specific IgG monoclonal antibodies have been generated. And these were two antibodies called RegN 1908 and 1909. And these are two high affinity, fully humanized IgG4 antibodies specific to two different epitopes on the FeLD1, on the major allergen of the cat. And these both antibodies have been screened, or many antibodies have been screened for the binding capacity. And these were antibodies from more than 300 different monoclonal antibodies. And these antibodies were generated by a special system. This is called Veloc-Immune in a mice. And in this system, they can produce human-mouse hybrid antibodies. And these antibodies are rapidly convertible to fully human antibodies. And therefore, we have fully human antibodies, IgG4 antibodies, against these two FeLD1. They're directed to FeLD1. And it has been shown that these antibodies together will block FeLD1 binding IgE, will inhibit the mast cell degranulation in vivo, and reduce really symptoms in patients suffering from cat allergy. And at this time, two trials have been published. And those trials have been similar, are done in a similar way. You will find here that cat allergic patients have been analyzed by total nasal symptom score, by a challenge with the cat allergen, and by the nasal flow. And then those patients have been treated with one injection of the antibody or with placebo. And after that, the patients have been elevated till day 85. And here first you will see the skin prick test in those patients. And this is a skin prick test with cat allergen. And this is the effect of placebo. And therefore the patients have a positive skin prick test before and after the treatment with placebo. And here you see those patients who have been treated with the IgG4 antibody against FeLD1, and you will see a reduction. Here on day 29, the patients got only one injection, and you will see the reduction also here on day 85. Therefore, we have a long-term induction of tolerance here shown in the skin prick test due to this antibody. And you will see here the total nasal symptom score by challenging these patients. This is a placebo effect, and therefore also in placebo you will find in all these trials placebo will have some effects. But this is the effect, and therefore the reduction of the nasal symptoms due to cat allergen in these patients, and you will see here a dramatic reduction of the clinical symptoms, and this is also here shown over a time of 85 days by only one injection of this blocking IgG antibody. And these are patients with a reduction of more than 60% of the total nasal symptom score. You will find that also in placebo in some patients, but you will see here nearly 60% of all these patients had a dramatic reduction, therefore for more than 60% of the total nasal symptom score. And this has been demonstrated over 85 days. And that's really, I think, a very interesting effect. There has been a second trial. This was also phase 1b. And here 36 patients again received the IgG anti-FeLD1, the combination of these both antibodies. 37 received placebo. And again, here a nasal challenge has been done. And in this case, again, with a hair extract. Therefore, in the hair extract, you will not find only FeLD1, you will find also other allergens or other components of the cat. And again, here you will see what we can reach. And this is a visual analog score of the patient. And you will see these are patients treated with placebo. Yes, placebo has some effects as we estimated, but this is the effect of those patients who got one injection. And again, here you will see the effect. This is a concentration in the serum of those patients of these IgG antibodies, of these both different IgG antibodies. And you will see here you have a high concentration after 1 month. You have a low concentration after 2 months, and here after 85 days, we have again an action of these antibodies, but the concentration is quite
I'm
low.
sorry to disturb Dr. Weller.
Yeah.
Yeah. Can you summarize this thing in 5 minutes now?
Yeah. Yes, I will finish it now.
Oh.
Therefore, in these studies, we have a high correlation between the inhibition of allergen binding and improvement in the total nasal symptoms. Therefore, it seems that these IgG antibodies are highly effective. And here you will see what trials are going on at this time. And we have a study, a worldwide study on FeLD1 with these antibodies, with IgG antibodies. And we have already a phase 3 trial with a birch pollen IgG, with a BETV1 IgG antibody. And this study has already started. Therefore, allergen-specific IgG antibodies are induced due to allergen immunotherapy. And the administration of allergen-specific IgG antibodies block mast cell activation and really suppress allergy symptoms. IgG antibodies against a single allergen component protect, and this seemed at this time, against symptoms due to a challenge with the whole allergen extract. And that's really very important for me. Therefore, allergen-specific IgG antibodies, and in this case, they are really a biologic, may become a new treatment option for allergies. The question is, we have allergen-specific allergen-specific immunotherapy. And if we can use this kind of therapy, perhaps in the presence of immune stimulators, of adjuvants, and if we really can increase the induction of allergen-specific IgE antibodies to a level that we have similar effects is really unclear. I think at this time, the anti-IgG, which we can induce by immunotherapy, the concentration is too low. But if we could induce IgG antibodies in a concentration sufficient to block mast cell activation, then we had here another option to treat patients and to have really a mast cell or effector cell silencing effect. And I think this may be a new strategy to get tolerance of patients against individual allergens. And that is what I wanted to demonstrate today. Thank you very much for your attention.
Thank you very much, Dr. Weller, because I know this topic is very long, but anyway, you have made it very clear about your concern and about that new idea of IgG antibodies and can we use it for therapeutic purposes. We can have 1 or 2 questions, not more than that, I think.
Okay.
Sir, can I have a question, please?
Dr. Jain, please.
Sir, I'm Dr. Anil Jain. I am from National Institute of Tuberculosis and Respiratory Diseases and basically running an allergy clinic also there. You made a very good presentation on the newer concept of IgG induction. Because this immunotherapy takes some time to give its effect, for example, the 6 months, 1 year at least. Yeah. Can we introduce the specific IgG first as a passive therapy till the active IgG production becomes active?
Yeah, that's a question. Here you saw if you will really give the IgG antibody, it will act really very quickly, and it has a long effect. I think due to specific immunotherapy, the concentration is not high enough. And the antibodies in different patients are really different. That is a problem. Therefore, some patients may have highly blocking IgG, others may have a low blocking IgG, and this may be the difference in the effect on patients. Therefore, I think this is a new principle, and I would estimate perhaps we can combine the both treatments, and perhaps we can have a very fast, a very quick effect by giving these blocking IgG, and on the other hand, a long-term effect by immunotherapy, but this is pure speculation. If this will come, I don't know. But I think the IgG is important also as a mechanism for the use of specific immunotherapy and in the action of immunotherapy.
Thank you. Thank you.
Can I hear?
Yes, Dr. Kathuria.
Greetings from me, Dr. Prayer. I am Dr. Kathuria from Delhi. Outstanding presentation, sir. Always love to learn from you.
Thank you.
Questions pertaining to the origin of the IgG, allergen-specific IgG. Still, we are not clear whether this allergen-specific IgE is independent of the B cells in the presence of the immunomodulatory cytokine IL-10 or TGF-beta? Or is it the same plasma cells which from original B cells which class switch to plasma cells to synthesize IgE and then it go into the IgG? Or is it a independent allergen-specific IgG4 without any cytokines? And the second question, sir, which is very important for us, you mentioned the allergen-specific IgG as a passive immunotherapy. Do you think in future, because we need LPR suppressions initially with the allergen immunotherapy, we want LPR suppression, which is due to the FAB suppressions, the facilitating antigen binding by the allergen-specific IgG, and they are long-lasting. Will this adjuvant will be long-lasting, or it will just every month or every 2 months we have like a biological, it will be there?
I think we do not have the data at this time. This is really a very important question. What about the long-term efficacy of this kind of treatment? At this time, we have only patients who have been treated with one injection. And it has been shown, yes, giving one injection, we have an effect for nearly 3 months, or a very good effect for about 2 months. Therefore, at this time, we think we must repeat the injections. But if we treat patients for a longer time, let's say for a year or so, if we really have an ongoing silencing of mast cells, we do not know that. Well, this is really unclear. We have to investigate in clinical trials the long-term effect, and these trials are underway now, and we have to wait for that. This must be IgG or IgG4 is all.
Yeah, there is one more question from Bangladesh.
Okay.
In the midst of so many biologicals, where do SCIT and slit stents?
Pardon? I didn't understand completely.
I think from Bangladesh, Dr. Mohidul has asked that in Bangladesh, our experience with sublingual immunotherapy is quite good in reducing the perennial asthma symptoms. In the midst of this, so many biologicals are available. And where do the immunotherapy stands today?
Where do you stand? What do you stand among all these biologicals? Where does SLEET and SCIT stand?
For me, it's clear, and what I demonstrated, I think the biologics are for the patients with really the severe asthma, therefore GINA 5. And immunotherapy is more for the milder asthma. Therefore, you must estimate that you may have side effects, and there are also asthma attacks due to immunotherapy. And therefore, if you will give immunotherapy in highly affected patients, then you may have severe side effects. And therefore, my view is that immunotherapy is for the milder affected patients, and biologics are for the highly affected patients. IgG antibody could be also given in highly affected patients, and therefore it would be an option also for those patients who have a severe allergic asthma and are treated according to GINA 5.
I think, Dr. Weller, yes, so I finished off asking two important comments from my side. One is that in severe asthma, you said the immunotherapy should not be done. And I am just having the views just other way around, because asthma fluctuates. Today it may be severe, after treatment for 2-3 days, it may be mild. So it's very different. And I think that the severe asthma, if it is because of allergic reactions, they respond very well to immunotherapy. That's what my feeling. And number two, question is that, or comments rather, is that anti-IG, if you're giving anti-IG, and there is any chance of making anti-IG antibodies in the body instead of giving benefit that can be slightly harmful?
I fully agree. Nevertheless, immunotherapy needs a long time to be effective, therefore several months, and normally we can see the first effects after about 4 months, and we will have normally a good effect after about 12 months. The biologics are really quicker. And therefore the combination of these therapies may be a very good option. Therefore, we can reduce the symptoms quickly by a biologic, and we will have long-term effects by immunotherapy. But because at this time, all the biologics do not have a disease-modifying effect. Therefore, we need really a long-term therapy, a long-term treatment over years, and that is very expensive. We know that. And therefore, for many patients, immunotherapy may be the better treatment because we have the long-term effect. Therefore, I'm really happy to have both. And perhaps we will more combine these kinds of therapy.
Sir, can I have one question, please?
I think, yeah, that's
just one.
Just the last one. Because
Yes, sir. So, thank you so much for this wonderful presentation. I am Dr. Taha from Jammu and Kashmir. Sir, you in the middle of your talk said that we measure the skin pre-test reactivity vis-a-vis the response to this anti-IG regimen.
Yeah.
Even in allergy immunotherapy, we have learned that skin test reactivity should not be repeated, and it is no way an indicator of whether the patient has responded or not. It's actually the symptom score and the medication score of the patient. That is even what I have observed also in my 6 to 7 years of experience in allergy.
Yeah.
So why do we really need to do SPT? And in case there are many patients where we repeat SPT just for the sake of learning it, experience, they still have the same skin reactivity, sometimes even more what was present before giving immunotherapy. But symptomatically, symptom score was very good. The patients were almost free of symptoms and medication as well. I mean, I just want to get a little clearer picture about it, sir.
Yeah, I fully agree. I think the skin prick test and also the IgE is only to make the diagnosis and to find out against which allergen the patient is really allergic. Here in this trial with the IgG, it was only demonstrated that you will have also a reduction of this surrogate parameter, and this is also the skin prick test in this case. Therefore, it was only shown you will have an effect on that, but this is not of importance in our patients who are under immunotherapy. Therefore, normally the skin prick test will stay positive. Also, the specific IgE antibody will stay positive also under the treatment of specific immunotherapy. But it's useful here only in this trial to demonstrate that the patients are less allergic or may have a decreased reaction to the allergen. Important is the clinical significance. I clearly agree.
I think what I want to add about this thing, that one is that a clinical investigation will show that you are allergic, or rather we can say you are hypersensitive to a particular allergen. And once the symptoms are present, then and symptoms related to that particular history, then we can say, okay, the patient is allergic. So always there is differentiation between hypersensitivity and the reaction and the allergic reactions. Once the patient is proved as allergen, then you have to see that only the patient has to be hypersensitive first in most of the cases, and then develops the clinical symptoms. So I think with this, I thank Dr. Breyer very much for bringing out. I think I heard your most of the lectures, previous one, but this one is a new one, a new idea, new things which you have introduced. And let us see. I still feel that there should not be any anti-IgE antibody formation once you give the IgE injections. Hopefully not. So I think thank you, Dr. Brenner, very much.
It was a great pleasure for me. Thank you very much for having the opportunity to speak here.
Nice.
Thank you very much, sir. Thank you.
Thank you.
Can I go to the now next speaker, Dr. Nagin?
Yes, sir.
Do we have time? Okay.
Welcome, Dr. Khilnani.
Sir, good morning.
Yes,
Good afternoon.
Good afternoon.
Just a minute. Yeah, Dr. Khilnani. I think next is Dr. Khilnani. I think all of us know Dr. Khilnani very well. He's the chairman of PSRI Institute of Pulmonary Critical Care and Sleep Medicine at New Delhi. He has been ex-professor and head Department of Pulmonary Medicine, Sleep Disorder at All India Institute of Medical Sciences. He has been past president of National College of Chest Physicians, India, member of Council of International Governors and Regents, American College of Chest Physicians, member Executive Council, Indian Chest Society, chairman Credential Committee, Indian Society of Critical Care, and there are so many things attached to his credit. And already we are running short of time. I think I can ask Dr. G.C. Khilnani, a personal friend of most of us, to please give his talk. Management of asthma in 2021. As I know, Dr. Khilnani has been on TV for most of the related to corona for about more than 1.5 years. And he's a very known face, and he has given very good advice also to the general public and to the medical fraternity. So now we'll be talking about management of asthma in 2021. Dr. Khilnani, please.
Good afternoon, ladies and gentlemen. Thank you very much, sir, Dr. God, for generous introduction. Also, my association with Corona. We all are associated with Corona these days, but I took a pledge of, disseminating information, and that's what I have been doing. And I'll also add that part into asthma also at the end of my talk. I feel a little nervous and scared with so many senior people like Dr. Rajendra Prasad, Dr. Gaur, and luminary of allergies sitting here and me talking about management of asthma after a splendid lecture on the basics. So I think there would be some people would still be interested in knowing what is the management of asthma at the ground level in 2021. Has there been any changes which have occurred? So forgive me if at some point of time you might find this deliberation very primitive. But what I'll be doing is that I will be highlighting a few things which I think are important for the younger people also in the management of asthma. So
can we increase the voice level a little more, because the voice is very feeble, which I am getting.
Dr. Khilnani, make it 100% from your
No, mine is 100%, sir. There's something from the I checked it. So I'll be a little louder. Is it better now?
Or keep the system closer to you.
Yeah, no, I am using the wire, so
Okay,
that's not a.
Go ahead, sir.
So, talking about asthma deaths, dying needlessly because of poor care, 334 million asthmatic, 250,000 deaths annually, and deaths in the developing countries.
Dr. Please mute your mic, Doctor. Yeah.
So this is what is troubling, and 2 out of 3 deaths of asthma are actually preventable, and that's what is bothersome to all of us. And talking about burden, that there are 8.4 exacerbation per year, each exacerbation lasting for 4 days. These are Indian data. And 50% of asthmatics reported 3 to 10 exacerbation per year, and 20% reported more than 11 exacerbation per year. Is it acceptable in 2021? That's a question. And going into the history, before I was not 1972, but they with theophylline and tablets. 1972, the inhaled corticosteroid actually changed the game. And as we progress, as we had thermoplasty, we had GINA, we had now antibiotics are being used, and I'll be talking about everything. So omalizumab came in 2003, which Dr. Breller talked about it. Anti-IL-5 came in 2016, and we have several others biologicals, and of course bronchial thermoplasty, and of course slit therapy also is coming. But what is the basics? What exactly we want to do when we are managing asthma? And this was a headline: class 9 student dies with asthma in the school. Another child dies in the school, and parents blame the school. So can we do something about it? That's the question. On the other hand, there are people who have achieved everything. You know, ice skater, David Beckham, you bend like Beckham, the football season, Alan Border, and people climbing this Everest. But he should be able to climb the Everest. Can we do that? And for that, we need to know what are the goals. The goal is that there should be freedom from frequent symptoms. That is the minimum need exacerbation, that is prevent the reduction in the lung growth in children, that is extremely important. And prevent the loss of lung.
Sir Kilani, your voice is disturbing. Somewhere your connection. Yeah. Your words are
like
disturbed.
COPD. Last 4 weeks, as the patient had
broken voice.
Dr. Khilani, your voice is breaking. I think there's some internet issue.
I'm just now.
Mr. Chairman.
Not able to hear your voice. It is disturbed.
Yes, Dr. Singh. There's some local disturbance with Dr. Kilani's mic or connection.
Yeah.
Okay. Is my voice better now?
Yeah. Yes.
This is better.
It is better?
Yeah.
Yes.
Okay. So I'll speak without a wire. So when we are managing asthma, in the past 4 weeks, has the patient had daytime symptoms or control? Any nighttime awakening, reliever needed for symptoms more than twice a week, or any activity limitation in asthma? Well-controlled asthma should have none of these. A partly controlled asthma should be 1 to 2 of these, and uncontrolled asthma will be having 3 to 4. So poor asthma control itself substantially increases the risk of exacerbation. That is one. 91% of Indians perceived their asthma to be controlled. However, none had controlled asthma by objective parameter, and asthmatics in India believed that their asthma was under control if they have up to 2 emergency doctor visits a year. So therefore, factors contributing to poor control of asthma are physician related, they are patient related, and I'll be talking about it, and I don't think anybody is to be blamed. But the most important part is incorrect diagnosis, a poor access to the healthcare, unaffordability of asthma, exposure to environmental irritants, non-adherence to the treatment, and poor inhaler techniques. So I'll be talking about managing patient with asthma by showing you some cases. The first case is 21-year-old girl who had history of allergic rhinitis since childhood, currently not significant symptom. Recently shifted to Delhi, had episodic dyspnea and wheezing for 2 months. predominantly in the evening and early morning, frequent night awakening, recent upper respiratory tract infection, has partial improvement with symptoms with over-the-counter cough syrups and anti-allergic drug, and has a history of asthma in mother. This is the classical features that we see, and on clinical examination, she had polyphonic wheezes, but the PFT was normal. So a clinical diagnosis of asthma was made. So coming to the diagnosis, the wheeze, shortness of breath and chest tightness is important, which is confirmed by documented airflow obstruction, which of course we know is FeV1 upon FVC ratio. And you can also diagnose it by excessive variability in peak expiratory flow rate or in FeV1 by 12% or 200 ml. So FeV1 upon FVC ratio is a limitation in the diagnosis of obstructive airway disease. So therefore, population-specific normal values are upcoming in India, but that cannot be taken. So what does the GINA guidelines say? This is 2018, which said that as needed short-acting beta-2 agonists are to be taken. Step 1, you consider low-dose ICS with SOS short-acting beta agonist. Step 2 said leukotriene, low-dose inhaled corticosteroid. Step 2 also said you could add leukotriene antagonist and or low-dose theophylline. Step 3 said ICS LABA with medium or high-dose ICS. Step 4 said add LAMA, low-dose ICS with LTRA. And step 5. Now, the question is, what change has taken place? So patient was initiated on ICS and LABA as required. And what is 2020 what GINA said? Based on the SIGMA trial, there has been more emphasis on inhaled corticosteroid and even in step 1. So even in step 1, it is advisable to start ICS and formoterol in step 1 as well as step 2. There's more emphasis on low dose maintenance inhaled corticosteroid in step 3. And leukotriene antagonists have taken a backseat. This is because of the black box warning. And even in step 4, it is advised the medium dose maintenance ICS and formoterol should be used. The LAMA has been shifted to step 5. And of course, the phenotypic management has been emphasized, and I'll be talking about biologicals very briefly because it has been talked in greater of the detail. So coming back to this patient returned after 3 weeks. She had minimal relief in dyspnea, chest discomfort, persistent nocturnal symptom, and morning sneezing with nasal stuffiness. What should be done? It's important to reconfirm the diagnosis on follow-up, especially in non-responding or difficult to treat cases. So I'll here show another case to show some differential diagnosis. This is a 61-year-old gentleman, retired resident from Bihar, presented with complaints of episodic dyspnea, bilateral wheezes, improvement in inhaled bronchodilator, but she also had feverish and recorded low-grade fever. And this was the X-ray, which is almost normal. The right diaphragm is slightly up. But when we did the CT scan, we see some amount of bronchiectasis, but little bit of nodules were seen, if you can see it on your screen. And when he was investigated, his absolute eosinophil count was 1460, it was raised IgE. The PFT showed mild restrictive pattern and decreased DLCO. A diagnosis of tropical pulmonary eosinophilia was made. So that should be kept in mind depending upon the... Another case was 35 years old male, known case of asthma over 20 years, poorly controlled. And when the CT was done, you can see high attenuated mucus. The diagnosis is written on the face. But come to think of it, 20 years this patient was suffering from ABPA. Without being diagnosed, his total IgE was 3,400 and with the specific IgE of 0.45. So he had bronchial asthma with ABPA. Another case of 40-year-old female with exertional dyspnea, periodic worsening, bilateral wheezing. X-ray was normal. When the CT was done, it shows nodules.
It showed bronchiectasis, as you can see, classical ring shadows, and this patient had small airway disease. So therefore, the diagnosis is extremely important. So these are the common pitfalls which are there. I don't have time to go into that. So the repeat PFT of this particular girl showed a 0.69 now FEV1 upon FVC. So now we have a diagnosis of asthma, even on PFT, but patient has uncontrolled symptoms despite treatment. So what should we do? The most important thing is to have a look at and this I started doing at AIMS. I asked patient to do, how do you take your inhalers? So this was a gross abnormality, and we all know that it happens all the time. So this was an uneducated person, you can say, COPD, but this was a lab technician. She said, I'm taking it properly. When I asked her, please show me how you take it, and you see how she's taking it okay, but she has actuated the inhaler at the end of the inhalation. So considering all these facts, it is very important. So this patient was not exhaling properly before MDI. So again, we did a total IgE and specific IgE were normal. She also had allergic rhinitis, only comorbidities. So therefore, what should we do? Should we increase the ICS dose? Should we add Montelukast and antihistaminic? Should we add theophylline? Three choices. Not right now. Patient re-educated on MDI with spacer and compliance to the treatment, low dose nasal steroid added. So allergic rhinitis has to be addressed with asthma. That is a message. So follow up, asthma got controlled. She feels energetic. She is able to exercise without discomfort. Symptoms of allergic rhinitis also controlled. Should we continue same treatment or consider stepping down? Not yet. So the GINA said that recommend stepping down treatment once good control of maintained for a period of 3 months. So therefore, I don't think every physician is following that. If you want to have a good control of asthma, you must continue treatment for a period of 3 months. So another patient is a 36-year-old female who was diagnosed asthma, has chronic rhinosinusitis. She has gained weight during pregnancy due to recurrent oral corticosteroids. Had asthma for last 2 years. The BMI was 30.1 kg. 1 hospital admission, 8 exacerbations requiring hike in oral corticosteroid. On high dose ICS LAVA with antihistaminic, with steroid spray, with oral Montelukast, with levocetirizine, and 5 mg of prednisolone. Still, she had uncontrolled system. The question is, what do you do? How to approach such a case? So we reviewed the comorbidities and association. FEV1 was 58%. Eosinophil count was 400. Previously, it was 1000. IgE was raised. ABPA workup was negative. She had history of GARD. Obesity could be one of the factors affecting asthma control. Nasal polyps, she had bilateral and ethmoid sinusitis. Osteopenia was also there on DEXA and vitamin D deficiency. All those things have to be assessed in these patients. So this is a classical case of difficult to treat severe asthma. How do I go about it? Same GINA guideline. This patient will come into here. Now, as per the old GINA guideline, that tiotropium comes in step 4. The latest GINA guidelines have been shifted to 5. So what do we do with this lady? That's the question. The question is the tiotropium. There was significant improvement in peak expiratory flow rate and FEV1 in this randomized trial. That's why tiotropium came back into the lap of asthma, and tiotropium resulted in the non-inferiority to salmeterol and superior to placebo in patients in moderate to severe asthma. Now, so this patient, first we added tiotropium, low dose theophylline, and PPI was added. Underwent a FES for polyposis. Still has partial control. Needs low dose oral corticosteroid for asthma control. Not able to lose weight, is following dietary modification, but unable to do exercise due to dyspnea. What else can be done? That's a question. So is there any other treatment? Anti-IgE treatment has been talked about, and GINA 2021 says that step 5 treatment for severe asthma. Anti-IL-5, restylizumab, mepolizumab, all those things have been talked about. Bronchial thermoplasty, macrolides, and immunotherapy. So this is a classical diagram that we show. Omalizumab has been talked about in detail. We have benralizumab now available with us. Mepolizumab is also available. These drugs are expensive, should be used, and for that you need to assess IgE and eosinophil count, and I did not go into all this. So, omalizumab, of course, Dr. Brazer has spoken great detail, and we have used it for a long time. I'll just show you some evidence. How to select patient for omalizumab, and that is actually very important. The person should have severe persistent allergic asthma, more than 6 years of age. He should be on high dose ICS and LABA, positive skin test in vitro, reactivity, RAST, and poor asthma control. And this is very important. If the asthma, severe asthma, patient more than 6 years of age, uncontrolled with ICS LABA, multiple documented exacerbation, FE1 less than 80, skin prick test, RAS test positive, body weight 20 to 200, and total IgE 30 to 150. All these are there. He is a candidate, he or she is a candidate for omalizumab. And a meta-analysis have clearly shown that this therapy, and we have sufficient experience, and this is a study by our own friend Dr. Guleria and Dr. Talwar, which has documented in 126 cases that omalizumab is a useful drug. So this patient was initiated on omalizumab 375 milligram every 2 weeks. She improved symptoms over the next 6 weeks. Oral steroids could be stopped, no exacerbation, and she was asked to modify her lifestyle so that she can reduce her body weight. So therefore, for the mepolizumab, this is an important treatment option for patients with severe eosinophilic asthma. The absolute eosinophil count should be more than 300. People have little skeptical about eosinophil count in India because parasitic infections are common, but this therapy is also effective. And the analysis of 4 studies, DREAM, MENSA, HALDAR, and combined, clearly showed that mepolizumab reduces the hospitalization and reduces the exacerbation in eosinophilic asthma. Now, dupilumab, I don't think is available with us, but this is anti-IL-4 and IL-13, and it has clearly shown that 300 and 200 milligram dupilumab improves the FEV1 as compared to the placebo in this patient in difficult to treat asthma. So dupilumab effectively treated patients with moderate to severe asthma, provided significant reduction in rate of severe exacerbation, better lung function, and asthma control. Now there are other approved biological therapies for asthma. As I said, mepolizumab reduces the exacerbation, increases the FEV1. Restylizumab decreases the exacerbation, increases the FEV1. Similarly, benralizumab also does the same. This is, I cannot say is the future of asthma, but in most difficult to treat cases, this can be used but should not be used loosely just because you have it. First, you should try all conventional therapy. Is there a role of macrolides? Now, macrolides have also come in GINA 2021 guideline. A randomized ASIS trial, the randomized double-blind placebo-controlled trial, low-dose azithromycin 250 milligram thrice weekly, or placebo added to ICS LABA for 6 months. The primary endpoint was rate of severe exacerbation and LRTI requiring antibiotics during 26-week treatment phase. And it clearly showed the primary endpoint during 6 months was not significantly different. In a subgroup analysis, significantly lower PEP rate in eosinophilic severe asthma. If the blood eosinopenia, actually eosinophilia was less than 200, and azithromycin significantly improved quality of life, but there were no significant difference in asthma control. So another study, MS study, however, showed that azithromycin reduces asthma exacerbation compared with the placebo, especially when the eosinophil counts are low. So a word about bronchial thermoplasty, it came almost in India in 5-6 years back. Now we have an experience of more than 5 years, and studies have followed these up. It certainly reduces the exacerbation, but I have no time to go into the detail because I want to talk about COVID and asthma, because that is the more important in the present. But suffices to say the bronchial thermoplasty is an advance in treatment which reduces the exacerbation. It is especially useful for remodeled asthma. It is a very expensive procedure. We were doing it at All India Institute of Medical Sciences, and some other centers are also doing it. How do we decide? This is the last part of my treatment, and I think I will draw your attention to this. How do we decide which therapy is most likely to be efficacious in a given patient, especially in difficult to treat asthma? And there come the phenotypes and endotypes, individualized therapy or personalized medicine. Now, first I will talk about Th2 type of asthma. That is, there is a history of atopy. The Ig is more than 100, pheno is more than 30 ppm, absolute eosinophil count is more than 300, sputum eosinophil more than 2. So all these may not be present. So this is an allergic, if there is allergic predominance, it is usually early onset. Spring test may be positive. Skin allergies, significant allergies, allergic rhinitis with high IgE, with absolute eosinophil count less than 300, omalizumab is a drug of choice for difficult to treat asthma. However, in the eosinophil predominant, there is a late onset, skin test positive, no significant allergy, then also omalizumab will be a choice. However, if the allergic eosinophilic overlap is there, if there is aspirin intolerance is there, or severe allergic rhinitis is there, then leukotriene antagonist should be added. In ABP, of course, there is no choice. You have to add oral corticosteroid and antifungal treatment. In Th2 low asthma, where IgE is low, atopy is questionable. If the pheno is low, if the AC less than 300 and sputum eosinophil less than 200, it is called neutrophilic asthma. Where in difficult to treat asthma, the macrolides may be useful. LAMA, that is tiotropium, and now other glycopyrrolate may be useful. In asthma with remodeling changes, the bronchial thermoplasty can be tried. If the obesity is there, weight loss would be very helpful. And if there is a polygranulocytic asthma, then LABA, LAMA, and there is no specific pharmacotherapy. So this is the summary of this. Finally, I would like to talk about asthma and COVID, and I'll be just reciting what Gina has said. As that COVID came, there was tremendous amount of misconception. People thought that patients with asthma will have more severe COVID. People thought that inhaled corticosteroids may be harmful because they reduce the immunity, so therefore inflammation will be much more. So why not? And so many of our patients actually stopped inhaled corticosteroid because of that. And scare was all the time. So I'll read questions and then answers. Are people with asthma at increased risk of COVID-19 or severe disease? People with asthma do not appear to be at increased risk of acquiring COVID. And systemic review have shown that actually people on inhaled steroid may be, if at all, protected from COVID infection. Are people with asthma at increased risk of COVID-related death? The answer is no. Overall, people with well-controlled asthma are not increased risk of COVID-19 related death. However, the risk of death was increased in people who had recently needed oral corticosteroids. So therefore, it is important that our asthma patients should not be put on oral corticosteroid in the COVID time unless absolutely essential. We should try to manage with things other than oral corticosteroid. What are the implications for asthma management? It is important to continue good asthma management as described by GINA report with strategies to maintain good symptom control and minimize the need for oral corticosteroid. Have there been more asthma exacerbation during the pandemic? No. 2020, many countries saw a reduction in asthma exacerbation and influenza-related illness. The reason is precisely not known, but maybe due to hand washing, social distancing, and masking has led to reduced incidence of asthma. What about medication? COVID-19 and asthma medication. Advise patient to continue taking prescribed asthma medication, particularly inhaled corticosteroid. As I said, it has been shown to be beneficial. For patients with severe asthma, continue biological therapy or oral corticosteroids if prescribed. But as I said, there is some evidence that this will need to increase in the mortality. Are ICS protected in COVID-19 patient? In one study of a hospitalized patient aged 50 years or more, ICS use was protective, but it does not add to the mortality, whereas systemic steroids do. Make sure that all patients have a written asthma action plan. This is what GINA says. Increase controller and reliever medication when asthma worsens. Take a short course of oral corticosteroids when appropriate for severe asthma. About nebulization in COVID, there was a big scare. In the beginning, we said no to the nebulization, and there has been a paper by in the Lung India about guidelines for nebulization in these patients. You should avoid nebulization wherever possible. This is what GINA guidelines say to reduce the risk of spreading virus. Pressurized meter dose inhaler via spacer is preferred, except for life-threatening exacerbation. And when you are using mouth nebulization, use a mouthpiece instead of mask, because the mask leads to spread of the aerosol. What about infection control during COVID-19? GINA says that avoid spirometry in patients with confirmed or suspected COVID if community transmission is occurring in your region. So if I could tell my experience, in April, May, we stopped spirometry completely as the transmission in Delhi has come down. And in fact, I had to change the room, PFT room, which had, we do PFT in a room which has a window and exhaust. So if your PFT room is located in a place where there is no air circulation and it's air conditioned majority of time, it could be a risk. Follow aerosol and droplet contact precaution if spirometry is needed. Consider asking patients to monitor PEF at home instead of coming to for spirometry. Follow strict infection control procedures if aerosol generating procedures are needed. And of course, nebulization I've already talked about, and even non-invasive ventilation is a aerosol generating procedure. Follow local health advice about hygiene, strategies to use protective equipment depending upon the location that you are in. And now finally about COVID vaccination. And I keep getting SMSs and WhatsApp messages right from the beginning, from asthmatic patient and non-asthmatic patient and the patient who has had COVID infection. When should I vaccinate? Which is a good vaccine for me? Is there a risk? What GINA says, the question is, are COVID vaccines safe for people with allergies? In general, allergic reaction to vaccine are rare. There was tremendous hesitancy on the part of people to vaccinate themselves who had allergy, skin allergy, eye allergy, or especially asthma. The Pfizer and Moderna vaccine should be administered in healthcare and the healthcare facilities where management of anaphylaxis can be treated. Since these guidelines come from the United States and Europe, where Pfizer and Moderna vaccines are used, they are not talking about Of course, Covaxin is not used there and Covishield is also less used. These vaccines should not be administered to patients with history of severe allergic reactions to polyethylene glycol. Please note that, not with any or any other vaccine ingredient. More details could be found out, and usual vaccine precautions apply. For example, ask if the patient has a history of allergy to any component. If the patient has a fever or another infection, delayed vaccination until they are well. At present, based on the risk and benefits with the above caution, GINA recommends COVID-19 vaccination for people with asthma. So there's no questions. All asthmatics should be vaccinated. Those who have history of anaphylaxis should take that vaccine in the healthcare setting, where if there is a allergic reaction or anaphylactic reaction, that can be managed. Can biological therapy continue in patients who have want COVID vaccination? We suggest that biological therapy and COVID-19 vaccine should not be given on the same day, so that effect of either can be more easily distinguished. Influenza vaccination, remind people with asthma to have an annual influenza vaccine, but there should be a gap of 14 days between COVID vaccination and influenza vaccine. So my conclusion of my rapid deliberation is there has been more and more emphasis on inhaled corticosteroid for management of mild asthma in the recent guidelines. High dose inhaled corticosteroids sort of taking a back seat as the GINA, every successive GINA comes. Use of moderate doses of inhaled corticosteroids is emphasized. Some biologicals now added to the armamentarium as they are become available, they should be used. Use of azithromycin in difficult cases is emphasized, but I must say that we must do a ECG and monitor QT interval, because there are cases of arrhythmias and sudden deaths because of this, which should be discussed. And also rarely there can be hearing impairment, although the audiometry is not advised at the start of azithromycin therapy. Fortunately, COVID has not affected severity of asthma and in fact may be protective. After initial scare of asthmatic receiving COVID vaccine, safety is well established. Nebulization should be minimized in COVID times, but if it is necessary, it should be given with the mouthpiece, not with the mask, taking all the precautions. My seniors, ladies and gentlemen, thank you very much for your kind attention.
Thank you very much, Professor Khilnani, for a short and presentation in brief, but you could convey all your messages. So I think there are few questions to you. Can PCS in the form of dexamethasone can be taken in the inflammatory phase with SpO2 less than 95 in asthmatics?
Sorry, come again, sir. Say the question again.
Yeah,
OCS.
OCS. Yes, in the form of dexamethasone can be taken in inflammatory phase with SpO2 less than 94.
No, but is it in the context of COVID or it is the
COVID?
And COVID.
COVID, okay. So there's no problem with that. When the COVID and asthma are combined, and when the patient with asthma has COVID, the COVID take the priority. And in fact, there's no evidence that they have a worse outcome. They have if at all, it's a little protective. If according to COVID guidelines, if the SpO2 is less than 94% of the CRP is exceedingly high, or the other inflammatory markers are high, whether you give dexamethasone or you give hydrocortisone, you give methylprednisolone, all are same. As per the meta-analysis of which was published in JAMA, the dexamethasone is number 1, hydrocortisone is number 2, and methylprednisolone is number 3. But what is practiced in India that we are using, majority of people in serious cases are actually using methylprednisolone. What is important is that steroids should not be used in supranormal doses. In a patient weighing about 50 kilos, 40 milligrams of methylprednisolone or the dosage is equal to 40 milligrams of prednisolone, which is equal to 32 milligrams of methylprednisolone, 160 milligrams of hydrocortisone, or 6 milligrams of dexamethasone sufficient. And this patient should concomitantly also receive treatment for asthma in the form of inhaled corticosteroids. Thank you.
What about you? What is your opinion about mucormycosis in asthma?
There is a for that, sir, we have to talk about why there was an outbreak of mucormycosis, and there are various thought processes. Working at AIMS, I used to see only 3 to 5 cases of mucormycosis in a year, and why there were so many cases. The simplistic explanation was that there was uncontrolled diabetes in majority of cases because of the steroids or newly detected diabetes. But there were patients who did not have diabetes, yet developed mucormycosis. The thinking was that COVID causes inflammation in the upper airways, which makes a bed for mucor to cause infection, and which spreads. But there is no scientific evidence or thinking that inhaled corticosteroids would add to the risk of mucormycosis. There is no data to best of my knowledge that it does that. So one should be bold enough to treat asthma with low or moderate dose of inhaled corticosteroid without worrying about black fungus. But having said that, of course, any patient who has COVID, his blood sugar should be monitored. I think if the blood sugars are well controlled with or without insulin, there would be no risk of mucormycosis. And inhaled cortico is.
I think Dr. Kennani, you have made the point very clear. Now there was too much of panic about the mucormycosis, and there are so many thoughts about using steroid, this thing, because steroid has been used for asthmatics for a long time, not the new thing. Yes, there has been some other causes which has also been highlighted, because mainly hygienic causes which has produced the mucormycosis. And I also feel in the way that okay, use of steroid is not the cause and should not be prevented in the thinking that it may produce mucormycosis.
There are some other thought process about mucormycosis also. One is unhygienic use of mask was one, and there was some blame on industrial oxygen also. Another thing was thought that people are using steam inhalation 10 times in a day, which compromises immunity of the upper airways. But these are only thought processes. There is no evidence for that.
There is no evidence. I agree with you. In fact, there is no other question. I think
Dr. God, there's a Dr. God. Let me.
Dr. Pradyuman and Dr. M.K. Agarwal must be brief, please.
Yes.
Yeah. This is Dr. Pradyum Sharma. Dr. Halani, as usual, outstanding. There are 2 points. One, in the classification of asthma, we see that on a symptom basis, the daytime symptoms and the nighttime symptoms. The daytime symptoms are being classified on a week basis, while the nighttime symptoms are being classified risk factors on a month basis. Rather, it should be reversed, because asthma is said to be a nocturnal shortness of breath, wheezing, cough, which is more pronounced in nighttime. So the point is this, the second point is a variability. We see a serious patient, the variability, they said more than 30%. To be labeled as a severe persistent asthma, which I believe was it as a serious as the variability doesn't exist overall. So I believe if we reclassify the classification asthma on a clinical grounds, it should be the day symptoms on a monthly basis and night symptoms should be on a week basis. It should be reversed.
Dr. Pradyuman, Dr. Killani cannot do anything against Gina. You know this is Gina.
No, it's a discussion. No, I don't say do with Gina, but there's a liberty to be there to be discussed.
Pradyuman, ask some direct questions, which can he reply nicely.
No, we are here to discuss it.
Yeah,
and the biggest point, there have been mucormycosis has been observed. Sir, there's one point. Mucormycosis has been observed to the patient who have never been diabetic, number one, who have never been hospitalized. There have been many cases, they've never been hospitalized and they were not diabetic, still they had a mucormycosis in COVID-19.
Okay, sir, may I answer this
because
question?
of hygiene issue.
May I answer this question, sir?
Yeah, please, Dr. Killani.
Dr. Pradyuman, thank you very much. The first part was comment, not a question. But I will here share some of my experience, working in a relatively small hospital, 200 bedded, and our hospital was a COVID hospital, but you will surprised to know in last 1.5 months, I have seen 3 cases of post-COVID amoebic liver abscess, which was totally out of proportion. And one of the patient was 62 years old male who came post-COVID with fever. And I thought as a COVID, person who is drowned in COVID literature, I thought it is dysregulated hyperimmune syndrome. His CRP was 300 and I started him on enhanced steroids, which he responds very poorly. And 3 days later, as a part of investigation for fever, we saw, there was amoebic liver abscess, which was diagnosed with amoebic serology and aspiration, which I ultimately burst into the pleural cavity, probably because of the steroids, ultimately responded. And then we saw 2 more cases. What I'm trying to say that besides steroid, COVID affects our immunity. And we see more fungal infection. We see more secondary infection, not only of the lung, but of the whole of the body. So I cannot put all money on steroid, that steroid called mucormycosis. As I said, that even in the whole of my career, 30 years at AIIMS, I used to see minuscule cases, being a tertiary care hospital with a big catchment area, very occasional case of mucormycosis. But in this outbreak, we saw so many. So I think there is something to do with COVID affecting the immunity, killing the T cell immunity. I cannot say beyond that, but more you look, you will find it. Like we found 3 cases of amoebic liver abscess, which I don't see even once in a year,
But we may not find increased cases of tuberculosis also, post-COVID tuberculosis.
Dr. Pradyuman is sufficient. Dr. Khilani, I can say only one thing, that if he is going to increase the immunity problem or the asthmatic problem, the patient usually, once we give the stimulant, the asthmatic have been worsened than destroyed. So I don't agree with that this is the cause of mucormycosis. Whatever may be the cause, we are not still clear. Okay, except that the patient who is uncontrolled diabetes can have mucormycosis, or that person can have any kind of infection. I think if there is any question, Dr. Agarwal, yeah. Dr. Agarwal, your question is last question. We are going to off to that.
Thank you very much. The presentation you have given. I would like to only have two small questions. One is, when we come to Th2 high phenotypes, we have found immunotherapy with causative allergens to be giving good results. When we saw your concluding slides, you do recommend omalizumab, but you have not recommended allergen-specific immunotherapy there. That is number 1. Number 2 is, you have said that in patients of bronchial asthma, vaccination can be given. What about patients of allergic rhinitis with asthma?
So your first question, it was an omission. I should have added. And the last, when I was preparing slides this morning, maybe it just skipped my mind. So I agree with that. Patients with allergic rhinitis, asthma, there's absolutely no problem with the COVID vaccination. And I have so many of patients that I have been recommended.
Dr. Ryan Prasad, please brief.
Thank you, Dr. Khilani, for an excellent lecture as usual. And I have with you that forget about COVID. We have seen in past all the viral infections, they decrease immunity ultimately. We have seen many cases of tuberculosis developing in post-viral infections. We have seen many things in post-viral. So I agree that's something to do with the immunity of the mucormycosis, because mucormycosis is known that it happens in immunocompromised host. So I have same feeling what you have, Dr.
So I'll take you into the just let me answer sir's question. He is too respectable to
me. Yes.
Sir, Rajendra Prasad sir, I have read the history of Spanish flu, which killed 5 crore people. And it clearly says that there were more deaths because of the secondary infection rather than with flu. And staph was even, I mean, that's what they think. So what you are saying is, has a deep sense that all viral infection and this wretched disease, which is actually very severe, surely it kills our immunity. It kills our immunity, and that is the reason that other infections are common. Mucor is a fatal disease, 30 to 50% mortality. So therefore it has been brought to the attention, and I'm sure if you look for it, like I have found 3 cases of amoebic liver abscess in a period of 45 days in a small hospital. If you look for it, you will find several infections which are occurring with this post-COVID. So I totally agree with you, sir.
Dr. Gilani,
Can I one comment, one line?
this is the last question. I think this is one question
One
from,
comment,
from
one
the
line
chat,
only.
from the chat box. Dr. Kathuria, please. We have saw post-COVID 70% tuberculosis cases, 20% pneumonia, and 10% allergy and fibrosis equally in post-COVID. So, and then also you say skin and diabetes, hypertension, depressions are also found more. I think the partly you have already answered that because something COVID is giving a rise in the secondary infections. I think if you and the fibrosis, one thing I want you to emphasize on post fibrosis.
One only comments, that's all.
Just a moment.
Submission, Dr. Khilani. My greetings.
Dr. Khilani, let answer this question first. What is the post-COVID fibrosis incidence and what should be done?
So it's not a question, sir. It's a, so post-COVID fibrosis, occurs in fact, I yesterday only delivered a full lecture on post-COVID fibrosis. So I can answer your question in 2-3 minutes if you could give me. The post-COVID fibrosis, actually there are 3 stages of pneumonia that is occurred. One is diffuse alveolar damage, second is organization, and third is fibrosis. But what I've been seen in the autopsy study is that even in the first diffuse alveolar damage is first 7 days. 7 to 10 days is 14 days is the second, that is organizing stage, and third stage is fibrosis. What I've been seen in the autopsy studies that even in the first stage when people died, there were 2 things that they found. There were microthrombi in these cases. And second was that they saw fibroblasts even in the first stage. So the fibrosis of post-pneumonic fibrosis in COVID patient is different from fibrosis that we see in tuberculosis. It is not fibrosis of interstitial lung disease. It is a fibrosis which is a combination of diffuse alveolar damage with inflammation along with microthrombi, which have been documented in several of the autopsy studies. So they are totally, and we know that tuberculosis, fibrosis, we don't treat with steroids. But the fibrosis which is occurring with COVID, and I actually documented it by studies yesterday, that it's not that nintedanib or pirfenidone which will prevent fibrosis. No. It is the good management with corticosteroid number 1 and possibly with good anticoagulation and other parameters that fibrosis can be minimized. The antifibrotic drugs should not be used at the outset. They only reduce the consequences of fibrosis by reducing the decline in forced vital capacity and FEV1. So therefore, this is what I know about, and I could be as brief as I could.
Yes, thank you, Dr. Kelani. And Dr. Kathuria, want to ask questions, but be very brief.
Oh, just one, my personal experience that those who were on a biological, they never had a COVID infection. It means the biological may act as an
इसी में अभी फोन मिला रहा हूँ वेबिनार को.
COVID-19. That is my personal experience, Dr. Khirani. Is it so biological acting as a antiviral because none of our case developed COVID-19 infections? Comments.
How many cases do approximately?
I think I can say only on behalf of Dr. Khilani that Dr. Kathuria, you have been lucky.
Been lucky.
Dr. God sir has answered the question.
Yes.
And I totally agree with that.
With the small number observations has no meaning.
I think Dr. Kilani, thank you very much for sparing time. I know you are very busy on television as well as in the hospital.
No, I'm not busy at all, sir. Kya baat kar rahe hain? It's such an honor to be amongst the, senior most and most respected pulmonologists and allergists in this country. So you have given me that opportunity. Although asthma is not my strong subject, you know that, of course.
Don't say it. Don't say it, because nobody will accept that what you have delivered today. I think so. Thank you very much, Dr. Kalani. Thank you very much for this thing. And then go to Dr. Nagen Prasad with this. I think you can.
Yes, sir. Thank you, Dr. Gaur. And this meeting has come to the end with a very good conclusion. I thank the Dr. S.N. Gaur, and Dr. Radhav Brahler also has given an excellent lecture. And one comment I want to make with Dr. Brahel, we are all practicing immunotherapy over decades, and still we could not able to give an impact on the pulmonologists, dermatologists, pediatricians, and ENT people. Dr. Kilani has given a beautiful, excellent presentation with all the things except the immunotherapy. That means the fault is with ourselves. We are not giving a message to the people that this has got a big role. At least we had to focus on the house's mind and the pollen allergen immunotherapy. They are all very familiar with the bronchothermoplasty, but they are not very familiar with immunotherapy. Why? This is our impact on these people. I think management has come with a guideline and also area guidelines. We have to move forward, and we are making a conclusion of the day, and it was excellent, and we had a very good time. I thank the Rajendra Prasad to introduce the Kilani to this session. I'm very happy, and Dr. Bell has got up early in the morning and presented his sacrificing his sleep in the morning and presented. Very nice of you, sir. Thank you very much. Thank you. Have a nice time.
Okay, sir.
Thank you. Thank you.
Okay,
Thank you.
Thank you all. I have one small announcement, Dr. Nagendra.
Please,
on
please,
1st of August, we'll be having another webinar under the auspices of the Indian College of Allergy and Immunology. That is on pulmonary disorders in the current era, experts insight. This will be on 1st August evening. Details will be sent to all the members and faculties and experts who are present here. Do participate into that. We have got 3 speakers. We'll decide shortly, but links will be sent to you. By the
but we also have an allergy chat in the morning. Should we have an allergy chat in the morning, or we have only one session on the?
This is on 1st of August.
No, this is
evening.
by somebody.
We have another allergy chat program also for the 1st of August. Should we have a regular allergy chat, or should we postpone it?
I think. I think if you are deciding, we can hold up from the 1st of August, one lecture for 1 hour.
Okay. Okay.
But
in
my submission.
Evening we can have it, but it's not a regular feature.
I think better to postpone. It should be only one, because there are 3 lectures.
Yeah.
Yes, definitely. I think better is to postpone on that day.
Okay.
Okay.
So the
that you can discuss and decide later, Dr. Nagendra.
Okay. Yeah.
Dr. Singh, I want to ask whether that 1st August program is sponsored by somebody or some college of ICI.
Maybe sponsored by somebody, but it's under the auspices of the college. It's a college organization.
So I'm just asking also, is it sponsored through
you are very well aware. How can you say innocent?
No, I'm not insane. I'm confused because there are 2 things. One is Shaswat, one is Mayuri. Who is sponsoring this one?
Mayuri is not an organization. Mayuri is an individual.
I'm getting the email.
You go through your mails. I will discuss later. It's not the forum to discuss.
Please discuss it. Okay.
Any more message?
No, can we discuss with the duration of the allergy chat, because already question is going on. So shall we discuss here? It is good enough to give 5 minutes to each one.
Okay, sure. The number of
Everybody has already expressed his views.
Yeah.
And now the convener will take the decision.
Yes, yes, I think everybody has expressed his views. Because what I'm trying to say, too much of things will spoil. So to get a speaker, to make it a continuous process, what I suggested once in a month
is good.
Maybe 1 hour, 2 hour, what the wisdom decide. But too much, because a lot of people are practicing, lot of people, it interferes with so many things.
I
So,
think I agree with Dr. Prasad. I agree with Dr. Prasad because we are having every month the NCCP webinar, ICS webinar, allergy webinar, allergy you are said for that webinar, and they are webinars from my institution where I am working. So they are now too much actually. It should be something which should be digestible. It should not be overflowing or cannot be assimilated. That should be. So I think have the lesson numbers.
But
is
all
sufficient.
these webinars are not for everybody, Dr. Sahab. That is for the interest actually. Just like any meeting or conferences, so many simultaneous sessions are going on. So wherever I'm interested, whatever we will participate in that.
I think it is the collective wisdom.
Yeah, basically, what I have suggested.
All NCCP.
And you decide for one lecture or two. Today Dr. Beller has talked very well, and he took about 40 to 45 minutes. But anybody who is speaking on it, he will take time. So that because whatever we discuss in one day, it should be discussed in detail.
Fine.
That's why one lecture per seminar is okay, and it should be done early morning, in my opinion, so that the remaining day remains available for the clinicians who want to do something. But I think regularity mean एक lecture रखें बस, लेकिन उसको every alternate week मेरे ख्याल में रखना चाहिए, जिससे continuity रहती है और हम लोगों का interaction personal भी होता रहता है. बाकी इट इज अप टू दी कन्वीनर. हम लोगों ने अपनी व्यूज एक्सप्रेस कर दी. मैं तो कहता हूँ 8 बजे सुबह कर दीजिए, 8 से 9 1 घंटा करें और उसके बाद पूरा दिन खाली.
I think Dr. is still on the line, isn't it? Dr.
You can keep it in the afternoon by 4 o'clock.
Afterwards. Is still Dr. Weiler and Dr. Khilani is online. So I think it's better we can discuss all these things afterwards. This is not the time to discuss all those things.
Okay.
I feel it should be once a month and should be from 10 a.m. That's all.
My submission is again at the end.
अभी बाद में कर लेना.
We will not discuss this issue now.
I thank Dr. Brera. I thank Dr. Khilani.
What I suggest, Nagin, what I suggest, you can have one separate.
We will have a chat program in the WhatsApp group, in the core group, and we will conclude it, and we will give it to me, and we will conclude.
Yes.
Go ahead with
Dr. Nagen Prasad.
Yes, sir.
Please conclude. I'm going to have another webinar now.
Okay, sir.
Within half an hour. So I think please.
Okay, sir. We are leaving now. I think we don't have a session on 1st of August, and we will be having subsequent. That is falling on the 15th. That is on the Independence Day. So is it okay for Independence Day program?
No, not at all.
Not a program on
holidays, no.
Independence.
We are all
okay. We will have a discussion on
later on.
Then we will conclude.
Okay, thank you everybody.
Okay,
I am leaving now.
Bye.
Okay?
Thank you. Bye. Good day.
Thank you. Good day. Good day.
Thank you.
हाँ डॉक्टर जैन, अब आपकी शक्ल दिखी
at the end.
डॉक्टर गॉड चले गए क्या?
हाँ, everybody is gone now. Okay, Dr. Agrawal. Good day.
Okay, Dr.
हाँ, okay. Rajendra Prasad, Paramjit telephoned me. He has WhatsApp me regarding the, because our course is going on 29th and 30th regarding our KGMC. You know it?
Who? Who phoned?
Paramjeet.
Paramjeet,
Oh,
okay.
not phone. Paramjeet. You. So I don't know, because on that day I will convey program they have not made so far.
परमजीत ने क्या फोन किया?
फोन किया था कि 24th we will have a KGMC meet. मैंने कहा था कि 29th 30th हमारा अपना प्रोग्राम है, हमारी अपनी ट्रेनिंग कोर्स है. तो 24th it is okay, then I don't know, somebody already he has finalized or not. You might be knowing, पहले तुम्हें मालूम होगा आपको.
मुझे नहीं.
ठीक है, he might have missed that. और सब ठीक है सर. ओके.